me to be with you, my colleague, my chairperson, dear commentators, and I want to thank Power of Women and Dr. Anada for this invitation. Today I will talk with you as one of nightmares for endoscopists. It's perforations. The perforation is one of the situations any endoscopist want to be in this situation at all at any time. But it's a complication. It's known in all GI endoscopy, upper and lower, and today we'll try to discuss the colonic perforation. This is our objective today. The definition of perforation is a colonic perforation full thickening tissue defect involving the all layer of the colon, mucosa, submucosa, musculosa, serosa, and even causing a pneumoperitoneum. The perforation could be a secondary for an risk factor or many factors like inflammation, infection, obstruction, and could be due to a trauma or iatrogenic. And that's what we will discuss today. Of course, anyone who doing endoscopy, especially colonoscopy, he knows that perforation is one of complications known in diagnostic and also in therapeutic, especially with more advanced endoscopy procedure today, is the MRI, that have an advanced management for the colonic lesion. We have a high risk or more risk to do perforation. Some of this perforation may be in some procedure to be intended, like full thickness resection, but other it's an accepted side effects in ESD, EMR, and sometimes during the other procedures have this complication. Sometimes the pathophysiology differ from case to case. Some cases we have a perforation and complication coming from the leakage of the content or fecal content to the peritoneum, which may be a life-saving problem. Sometimes small perforation can spontaneously with the time to be big perforations. Also, we should respect any pain during the procedure or after the procedure of the colonoscopy. The perforation can be present by sudden severe pain and also can be a gradual increasing progressive pain. There is a different sites for perforation, and there is some sites more susceptible to have a perforation, especially the area of sigmoid due to its tortuosity and more difficult to pass through it, so the risk factor is high for perforation. Also at the rectum maybe have some risk, especially due to retroflexion in this area. But another area have a thin wall like right side of the colon and area of the cecum, so any intervention like pilopectomy have a higher risk in right side more than the left side. Also in the cecum, due to the thin wall, we have a high risk of perforation if this procedure is difficult and we use a lot of air insufflation. Causes of perforation, as we said, there is a spontaneous cause, maybe perforation due to rupture of diverticulum, infection, colitis, obstruction, trauma, malignancy. But this area that what we need to know more about is iatrogenic, which is maybe due to manipulation of colonoscopy or with intervention or therapeutic colonoscopy, polypectomy, MRI, ESD, or as I said before, maybe intend to induce in full thickness resection. The mechanism, there is a different mechanism for perforation. First of all, it's with the tip of the colonoscopy. When we push against the resistance, we can, through the tip of colonoscopy, do a perforation for the gut. Also, if we have a looping inside the colon and the endoscopist continue to pushing despite of the resistance, it could cause what's called lateral pressure against the bowel loop, and it's also causing perforation. When we do endoscopy with another pathology like stricture, diverticulum, if we go with the tip of the scope through the diverticulum, and we can do a perforation. Paratrauma, as we said before, due to excessive air insufflation and application of electrosurgical current, especially when we do polypectomy. Sometimes we use a high dose of electrosurgery current. The problem here, sometimes the perforation not appear at the time of colonoscopy, and it can be appear later on, after 1 or 2 days after this electrosurgical current causing what's called necrosing for the tissue, followed by perforation. So be careful, even when you do a polypectomy, sometimes perforation occurring later on. Of course, risk factor like in any procedure, if the patient have a multiple comorbidity, of course of bowel obstruction, advances of age, diverticulum, therapeutic colonoscopy have more risk for complication or for perforation. As we said before, the polyp located in the cecum or right colon, non-lifting polyp, when sometimes to do MR and try to inject to lift a flat polyp with a large fibrosis that can cause perforation if we during the polypectomy, and also the large polyp have a high risk for perforation. As we see in this picture, it's polyp after polypectomy, and what's called mirror site as here the resected part of the polyp, and this is the perforation. Post-ESD, of course, especially of the lateral spreading tumors. The management of perforation differ. If I have spontaneous perforation due to inflammation, usually the surgical intervention is the rule in that case. But in iatrogenic, we have many tools to have closing this perforation. First of all, we should prophylact ourselves from perforation, and we have endoscopic or surgical. How to avoid perforation? We have 2 things to do to avoid perforation. To avoid perforation, don't do endoscopy. Don't do endoscopy when colonoscopy is not indicated. Please don't do colonoscopy. Colonoscopy is contraindicated. Patient with intestinal obstruction, patient with comorbidity. Usually when we have a contraindication, we have a high risk of complication. When you or your hospital is not competent to deal with complication, you still not expert in colonoscopy or in management of complication, or you are in small hospital, there is no well-equipped unit to deal with perforation, so please don't do it. And second thing I had learned from Dr. Khalid, you should know when you stop. To stop, to continue the procedure is better than to have a catastrophe. Bad preparation of the patient. When you are going with a colonoscopy, you can see good, you push against the resistance, you have a high rate of complication. Difficult to advance the colonoscopy sometimes due to more tortuosity of the colon, or especially the area of sigmoid, you have some resistance. Please don't push, don't against resistance, and ask for help. Another colleague can do it, another more expert doctor can help you. Suspected perforation, sometimes when we are doing colonoscopy, we suspecting perforation, but we can't detect it. I feel I do perforation, but I can't detect. Please stop. Please ask your colleague, your more expert person to do, to complete the colonoscopy or to complete the procedure. Also, when you have a severe or deep ulcer or severe colitis, sometimes in cases of acute severe ulcerative colitis, we are doing colonoscopy without preparation. Yes, you can do it very rapidly. Examine the short colon, it will not be a hero when you complete the colonoscopy in this case, and you may cause a perforation. Of course, general measures should be done when suspecting perforation, like decompression with wire poor needle, treatment of the or stabilizing of hemodynamics, nasogastric tube, maybe antibiotics. But if you have a basic principle to do an endoscopic perforation, you should have a basic principle. You should approach it depend on the experts. If you are not expert, please stop inflation in the air and ask for help. Expert should be contacted as soon as possible, and positioning of the patient against make a perforation against the gravity to decrease the leakage of gastric content to the periton. And the expert endoscopist should be carefully examine the perforation and decide if it's endoscopic closure or we should go to surgery. The European Society of Gastroendoscopy guidelines recommend the consideration of endoscopic closure in case of perforation less than 1 centimeter. Gastrointestinal tract is clean. Procedure must be conducted by an expert endoscopist, and the patient should be general condition is good. Otherwise, go to surgery. We have many methods for closing of perforation. The most familiar or most famous is endoclip to create mucosal and submucosal opposition to close the perforation. Usually position of the wide open clip across the 19 angle over the perforation, and then put clips all over the perforating area. Additional clips can be perforated, doing it for large perforation. Suction of or decompression of the oil fluid, it should be done before withdrawing the endoscopy to minimize the leakage. This is a perforation, and we have 1, 2, 3, 4 clips to close this perforation. Other type of the clips is what's called over the scope clips. This differ from the previous one. It can take the whole thickness or the full thickness of the colon, mucosa and submucosa, musculosa. So give more position for the perforation and can be used for large perforation. This type is over the scope cap, and we have a grasper to catch the perforation edge and pull it inside the cap and insert the clips over it. And please don't make a strong traction for the tissue to don't track other structure behind the colon. Band ligation, it's described in some literatures and had used in when the clips is difficult to introduce, and also for small, very small perforation, you can use this band ligation. Another method is endoloop. Endoloop, when we have a large perforation, we have no over scope clips, we can use the normal clips with endoloop. How to can do that? We put on the endoloop over the edges of the perforation, then fix it with the clips 1, 2, 3, and to have the loop and the clips over the perforation edge, then tightening of endoloop. When you have pull the track of endoloop and try to approximate all the clips so we can complete occluded the large perforation. Here we fix the endoloop at the edge with the clips and then pull the endoloop to close the perforation. The most recent is endoscopic suturing. It has recently described by Apollo endosurgery. So over the scope, we have a device to suturing the perforations and full thickness, but The problem here, it's need a double channel endoscopy also to have a trained or expert in this maneuver. Self-expandable metallic stent can be used when you have a stricture perforation, small perforation in colon. We can put a fully covered metallic stent to complete obstruction for our occlusion for the perforation. Post-endoscopy management, of course, intravenous antibiotic. The patient should have a good bowel rest, and the patient should be closely monitoring. Conclusion, endoscopic closure of iatrogenic colonic perforation can prevent hospitalization and unnecessary surgery. However, expert endoscopists should take the decision to perform endoscopic occlusion or no, and also the method should take in consideration the patient condition, bowel preparation, diagnosis, available devices, and perforation. And before I said thank you, it's difficult situation for all endoscopists. Please, if you have a trainee or a young colleague facing this bad situation, try to be beside him, try to give him the trust. Don't push him or punish him. Please, the next procedure, let him to do it, to have his self-confidence despite he is going to the rule. And thank you very much.